Improving sepsis outcomes is our episode topic. My guest is Dr. Garrett Hartinger, Emergency Department Clinical Nurse Specialist at Henry Ford Warren Hospital. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Garrett, thank you so much for joining us today.
Hi, Nick. Thank you.
Before we get in our episode topic, can you share just a little bit about yourself?
I'm a doctorally prepared adult gerontology clinical nurse specialist. I went through the University of Detroit Mercy for my license, which I am fully accredited to be an advanced practice provider. I'm working for about 4 years in a level 3 Metro Detroit emergency departments, which is about 65,000 patients per year. Prior to becoming a provider, I was a nurse for about 8 years and a surgical ICU nurse for 1 year. As a clinical nurse specialist, I oversee 2 ERs and the quality metrics for both ERs. These range from sepsis to stroke, myocardial infarctions, traumas, and other CMS quality metrics. More specifically to this topic, I'm the co-chair and lead provider of the sepsis response team. I'm also the chair of equipment and supplies for both ERs, where I work directly with the vendors to figure out what the ER needs and what we should have, keeping in mind a Lean and Six Sigma approach to not have too much of what we don't need.
You said that you have responsibility over 2 emergency departments. What is their volume in each of those EDs and the makeup and the type of environment in which you're operating?
I work out of 2 ERs. They are technically the same hospital, but on 2 different campuses.
Okay.
1 tax code, 2 campuses. The first hospital sees around 65,000 patients a year as a level 3 trauma center. We are a primary stroke hospital, and we have cath lab on site. And one of our bread and butters at this hospital is our cath lab times. We're one of the best in the state for door to cath. The other hospital is much smaller, definitely a community hospital, around 20,000 patients per year, and operates as a level 4 trauma center. We do not have a cath lab on site, but are still a primary stroke destination. Both sites have an emergency residency program. Other residency programs include neuro, gen surge, ENT. So both are teaching hospitals with pretty robust programs. The residents bounce back between hospitals.
So if you're broadcasting to one group, you're getting them in both accounts. It's not like you need to worry about education for on the nursing side, clearly one side and the other, but from the physician group perspective, if you're hitting the residents, you're hitting the residents. Is that an accurate statement?
Yeah.
Yep. Okay.
One group, both hospitals. However, the nursing staff don't go back and forth.
Okay.
So I have 2 independent nursing cohorts.
Just for everyone's knowledge, what EMR system are you using?
Cerner.
Our topic today is improving sepsis outcomes. So, most nurse executives are familiar with what sepsis is and why it's so important. But just for a brief summary, can you talk about why that needs to be a critical area of focus for all nursing leaders on why we want to improve those outcomes and how it impacts not just the care of the patient, but also throughput for the organization and the bottom line?
Sepsis. It's the leading cause of death in American hospitals today. About 1/3 of all deaths in American hospitals are from sepsis. And on that comes a cost, right? ICU, time for diagnosis, time for treatment. So the inpatient cost of sepsis is somewhere between $40,000 to $70,000 per case. And the greater the delay in care, you get to those high numbers of cost. So if we can treat it within a few days, we're talking maybe 40 grand out the door. But we're talking multiple ICU nights or even weeks, that cost can get pretty high up there. It's also a CMS quality indicator, which is public data. It goes on those websites that any of our patients can see to figure out which hospital they want to go to, maybe which provider they want or which chapter they want their provider to work out of. And those hospitals matter, and those metrics that they put out matter. And I think there's a lot of strong data with the sepsis initiatives out there that CMS quotes a lot. And a lot of that is how many deaths we can prevent with good sepsis care. We're all here for the patients, and obviously mortality is huge. About 12.5% of deaths from sepsis could have been prevented if we completed the SEP1 standards of sepsis care. And unfortunately, compliance with the SEP1 standards are about 50% nationally. So not very good.
Yeah, and can you briefly review with us what those SCP-1 standards are currently? And I know that they do change and get updated. So what are they right now?
So they're split into kind of two factors, a 3 and 6 hour bundle. So in the first 3 hour bundle, we need to identify the SIRS criteria. Any 2 SIRS, whether it be a red blood cell counts, febrile, tachycardic, tachypnic, those all count. So any 2 of those with a source of infection qualifies for sepsis. If those things meet, we have to draw labs. So the labs will identify a systemic infection and further SIRS criteria. We need to draw blood cultures, figure out which bug this is and how to appropriately treat it. We need to get antibiotics on board within 3 hours of the identification of sepsis. And that can be pretty hard to do, is try to figure out if it or isn't sepsis. And then the last 3 hour bundle is providing balanced fluids for signs of shock. The preferred fluid right now is LR. Then moving into the second phase of the program is a 6 hour bundle. So within 6 hours of identification, we need to redraw a lactic acid to figure out, did we in fact reduce it by giving fluids, or are they progressed into shock? So with that, we need to reassess the tissue perfusion. That's why we're drawing the lactic acid. And then if they do have refractory shock, we need to add vasopressors because fluids didn't help. And one pressor may not be enough. We may need 2 or 3, depending on how refractory and how low that pressure is.
You talk a little bit about the low compliance rate, specifically with your role within the Henry Ford system. What have you done to address this, and where was it before you got involved, and where are you at right now?
I was a brand new CNS right out of grad school, and my director showed like, hey, let's test how well you know your stuff and what impact you can have. So the CNS works within the 3 spheres: the patient, the staff or nurses, and the system sphere. So backing up a little bit, when I first started, we had about 20% compliance in our SCP-1 bundles. So pretty darn low. So I had to figure out how to address this. My first thought was, so let's get multi-factors involved. Let's get every discipline that I can possibly talk to involved. Key stakeholders being pharmacy, medical doctors, medical directors, our quality team, senior nursing staff, and the floor staff. Those are that are on the ground doing the work. Once I got all that team together, we figured out, okay, we need a gap analysis. We need some data, figure out where we're standing. So I put it on our quality departments. Give me some data. I need to know the ins and outs of why we're applying so low. So with that, we had to get IT on board and get some data sent over daily on numbers. How often are we ordering the correct stuff? Leaving maybe labs unfinished on the nursing end. Then I also wanted to know, what do our abstractors show? Obviously, CMS is doing this data. I need this data sent to me as soon as they have it. So those were some barriers that we had to get over. But luckily got over pretty quickly. People agreed that, yeah, data is pretty important. And I feel like anyone up in that C-suite, you guys love data, which is key. So once we got the data, we started doing some root cause analysis, right? We needed to figure out, okay, so we know where we are. Why is this happening? So we sent out some surveys to both RN staff and the medical doctors to figure out, well, why are we not complying? What are you seeing? What are you feeling? And the things that got out from this was they didn't have enough education on the SEP1 bundle, that med schools are really teaching it to its fullest, and RN schools the same. They're not really teaching it to its fullest. So they didn't know enough about it. Other factors were poor perception of the bundle, that it doesn't work, or some of the published journals saying that the fluids aren't really necessary, that they don't really do much and can cause harm, or that the bundle's too complex, that these multi-steps and all these things that we must do and being timed on these things, it's really hard for an ER to buckle down and do both sets, especially to have someone in the ER for 6 hours is really inhibitory towards throughput. So we had a lot of factors there inhibiting us from doing well. So we brought this stuff back to the team and we're like, okay, what can we do to help increase compliance? We know what they're saying. So we went back to our education team for both medical and nursing, and we created some lectures for the residents, lectures for the nursing staff. We even created some mandatory learning plans that are annual. So every year they're going to be re-educated on the SCP-1 bundle and why it's important, and some of the literature that's come out showing the importance of completing the bundle and how it does affect mortality and throughput and the bottom dollar line. And we created some tools too, because education isn't the fix-all, right? So the first tool that we created was a documentation tool for nurses. It's a tool in which they can use in handoff. Let's say it's a 4-hour block in the ER. Every 4 hours, new nurses come on and they might hand off sets. So the nurse can fill out the sheet and tell the next nurse exactly where they are in the bundle, what is due next, and when the whole bundle can be shored up or closed out. We also created some sepsis macros, which is a dot phrase, you could say, for the physician's charting, where it is to plug in the numbers. It says something like, I identified sepsis at this time. This is the metrics that we met. I did these things to meet those metrics. And even I reassessed the tissue's perfusion at this time. So it helps us meet the metrics that CMS is looking for in the verbiage that they use. And lastly, we created a power plan. So instead of ordering all these labs and antibiotics and fluids a la carte, per se, the power plan, one click, boom, it's all there, hit sign, and now it's in. So we've saved time there as well. All this being said, we gave it a 3-month trial. There's a lot of interventions that we came up with in a short time. So we let it run for 3 months and we regathered the team and looked at some of the data coming back. And Nick, it had amazing results. We had a 300% increase in our SCP-1 compliance. They went from 20% compliance up to 60.
Wow.
Yeah. So a lot of work with a lot of payoff. So now we are above average in the nation. Shortly after my publication, though, our stats fell. Our stats fell quite a bit. So we went back to the committee. I was like, okay, well, let's look at the data. What is going on? What is causing this poor compliance? And it was something that we didn't really think of, that it's natural to most hospitals. So we had RN turnover. So all the education went out the window, right? We had these new grads that don't know the stuff. So we had to teach them. We had residents who graduated. So now we had these senior docs who are doing great, and now we had to train these new guys.
You mentioned that there was a setback and that setback was due to staff turnover. What were your next steps that you did as related to that?
Yeah, so we had to go back to the drawing board. So we met with the committee and we're like, okay, we can't obviously depend on our training, our education to fix our problem. We need something that is more consistent. We did a little bit of literature review for what other hospitals in the country are doing, and the sepsis response team came up. A team of hyper-focused nurses and providers that can respond to the bedside and help push this SCP-1 bundle and get it completed for all the stakes that are involved: costs, mortality, all those things. So we had to figure out what will this team look like. And we came up with, okay, we're going to have 6 nurses, 4 on nights, 2 on each weekend, and then 2 on days. So those would be the boots on the ground. We also had a medical director in which these nurses had a little bit higher scope than the other ER nurses. They could order a lactic acid if that wasn't ordered. They could recommend different therapies like, hey, let's get a IV inserted without even asking the provider. And they did this under a protocol which that medical director wrote. You also had myself as a new MP. I would respond to the bedside and help push that care. So instead of the nurses having to independently order these things, I could, including the antibiotics, which saved a lot of time off that door. So then we had to figure out, okay, that's how the team will operate. How will they get paged to bedside? So we had to create a code sepsis. It was called overhead, either at triage or when the nurse found the SIRS criteria being met.
Now, this sepsis response team, is this something that's available only in the ED? Is this a department-specific team, or is this a team that if there's a patient that develops sepsis on the inpatient side, that this response team would be responding to?
As of right now, it's just in the ED.
Okay.
It's a pilot. Pilot's been going on for about 2 years now. And we're starting to get back some pretty good data, which I'm going to refer to a little bit later in this podcast. We also found that nurses, especially new grads, have a difficult time talking with attendings or senior residents or chief residents. There's a little bit of intimidation there. We were training our staff on this sepsis response team how to handle those conversations. Some of them being, convince me that it's not sepsis. After all, sepsis is now a code. We run it as a code. Everything is super stat in terms of getting the orders in and completed. We have this mantra now of when the team is activated by the nurse to go to the provider and convince me it's not sepsis, just like you would convince the chart that it is not a stroke or not a heart attack. We had the same mentality for sepsis. And after we went back and after a year of this team being deployed, we reviewed all the cases that team was called onto. And Nick, this team had amazing outcomes. When the team was on the case, there was a 75% compliance in the SCP-1 bundle.
What about when they're not on the case?
It drops down to around 40.
Okay. And so a follow-up question with that, how often is the team available? Because like, I mean, I know you work hard, but you're not at the hospital 24/7. So do you have someone that's there on the team 24/7 and they're just not getting called? Or is this a Monday through Friday day shift kind of thing? Or how's this work?
There is always a sepsis response nurse there at all times. But a sepsis response provider is not there at all times.
Okay.
Really, it's just me. The nurses obviously can't get as much done as the providers can if orders aren't there, right? They can't order the antibiotic. They can order the labs, but not the meds.
What is the current status of the program?
While the team is being called, everything is wonderful, great stats. Without the team being called, it's around 40%. Our regional sepsis coordinator was reassigned to a different metric, and we haven't had one reassigned to sepsis. So the data has dried up the past few months. With all that, I still get the compliance, which is around 40%. So we're holding pretty steady without having a team of quality people behind the scenes.
What I hear you talking about is your greatest challenge has been, frankly, the integrity of the membership of the program, right? You've got the nature of the ebb and flow to begin with nursing staff turnover. You've got the nature of the ebb and flow of resident turnover. Those are a given, and there is really nothing that's going to change, at least the resident turnover. Nursing turnover ebbs and flows. In addition to that, you had a physician group turnover that's occurred, and then your regional leader that was responsible for sharing the data and the metrics and getting it to you. That's a state of transition. So what are your plans to hold this program together and continue to advance it and move it forward?
With the new attending group, we are reforming the multidisciplinary sepsis committee. They have partnered with us. I now have a co-chair physician in my team, and he was chair of the sepsis team at his last institution. I have a great partner now on this team. We ran a few RCAs, and the physicians don't know all of our current programs, including the power plan and the macro or that phrase, but whichever you want to call it. So we're educating the new attendees on what we have. And we're doubling down on the sepsis response team. Why can't this go housewide? Why can't we have a team just for sepsis at all times? Looking at some whole numbers there, Nick, we have around 300 end diagnoses of sepsis per month at our leading hospital. So we're looking into how can I expand this team and get them more independent, just working sepsis. So then working ER and sepsis. Going forward, we now have a twice a year residence lecture on sepsis, so they can't get away from it. It's always at their fourth thoughts. We also have sepsis lectures for the nurses at huddles and a academy for all the new grads. And then finally, there's me. I've become more hands-on. About 50% of my day now is looking at patients that either are confirmed to be septic, or I'm looking at the status of the patients in the ER and could they be septic? Then I'll self-activate myself to the bedside and ask the provider, are they septic? I see here is 2 SIRS. X-rays showed a potential source. Convince me it's not. So that's what we have going on right now is to help repair this program and get it back to, let's do 75% for everybody, even when the team isn't there.
Any closing thoughts as we wrap up this episode?
One of the new initiatives in the state of Michigan to help with sepsis and the mortality of sepsis. And they, out of nowhere, tell us that we have one of the best mortality rates in the state. We're a little over 16% under the state average. And in some months, we are 50% less than the expected mortality rates versus other hospitals in the state. So that kind of blew me out of the water. All this work that we've been doing for the past 2 years, despite all the barriers that we've encountered, we're having real improvements in our mortality, which at the end of the day, despite being a business, we're here for the people, and we're the people that can go home back to their families to have and have lives. And to me, Nick, that is more meaningful than anything else that I could do during my day is get you back home to your family.
Improving sepsis outcomes has been our episode topic. Garrett Hartinger, thank you so much for your time today.
Thank you, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.